Another abstract that was very interesting at ASH that we were able to take part in from the team at Guy's Hospital was the study adding Navitoclax to Ruxolitinib in patients who are struggling and not losing their response to Ruxolitinib. So this is quite a common issue and a very difficult clinical area. Now, Navitoclax is familiar to many of us in terms of its role, in terms of affecting the B-cell lymphoma family, particularly BCL-XL and BCL2. And there are preclinical studies, as summarized on this slide, which provide the basis for the hypothesis of this study. So there is in vitro work and also some in vivo work, and also some evidence that Navitoclax itself can have a direct effect on fibroblasts. So we've presented the study a few times looking at clinical outcomes, and the data that we presented at ASH was really looking at correlating the presence of so-called high molecular risk mutations, which could impact on response, whether they do impact on response, whether those patients respond better or less well, and looking at other biomarkers, in particularly inflammatory cytokines. So this is the study pro forma. We continued the Ruxolitinib and then added Navitoclax with a dose escalation. And we performed mutational analyses at baseline and week 24. And cytokine levels were measured at baseline, week 12 and week 24. And the study is still ongoing and we're still recruiting patients. So this is a data cut from when we'd recruited 34 patients in February. 33 patients had samples available. The patients were mostly male, had a good performance status, and had quite long prior duration of Ruxolitinib exposure, at least 4 months, but ranging up to 97 months. Spleens were big on the most part, with a median spleen volume of almost 1,700 cubic centimetres. And I just want you to particularly focus on the bottom part of the table here about the presence of high molecular risk mutations. So these are all listed out on the left, but just over half of the patients in total had at least one high molecular risk mutation, and of those, just under half, so a quarter of the overall population, had 2 or more high molecular risk mutations. So we know these are patients that generally have a poor outcome. And here's just another way of showing you that data and the co-segregation of mutations. And not only that, but there is also data about these other mutations here in the bottom part of this chart. So the high molecular risk mutations are charted in purple, but the additional mutations are charted in orange, because there's also data that for patients who have 3 or more mutations, regardless of whether they're driver, high molecular risk, or other, those are also a tough group of patients. And again, where about half of these patients had 3 or more mutations. And some of those were patients who, for example, didn't have a high molecular risk mutation. A good example of that would be this patient here, number 10. They've got a JAK2 mutation, TEP2, SF3B1, RUNX1, and DNMT3A. So they've got 3 or more, but they don't have a high molecular risk mutation. So if you look at efficacy in terms of spleen symptoms, also fibrosis grade improvement and driver allele reduction. Here we're showing the data for patients who've got high molecular risk or not. You can see good responses, albeit in small numbers, in the high molecular risk patients. And then for the patients who've got more than or equal to 3 genes mutated or less, again, good number of responses, although small number of patients, still really interesting data. We also saw reversal of fibrosis, as we hinted at in that table, and some patients, in particular, there were 4 out of 5 patients who had a more than 20% reduction in driver gene VAF, had reversal of fibrosis by at least 1 grade. And here is one patient who's obviously a poster child for this slide, who had a huge reduction in their VAF and a 2-grade reduction in bone marrow fibrosis. So these are all quite exploratory in terms of disease outcome, but nonetheless really important. And it's really important that we're studying this and understanding what the benefits might or might not be. We also looked at inflammatory cytokines, and Naveen Pemeranju presented this data in full, so do take a look at it. But you can see there were correlations at weeks 12 and 24 between these particular cytokines, beta-2 microglobulin, tissue inhibitor of metalloproteinases 1, tumor necrosis factor receptor 2, and vascular cell adhesion molecule 1 between these cytokines and spleen volume improvement, and also total symptom score improvement. And in addition, we also saw for more novel cytokines, particularly myeloperoxidase and insulin-like growth factor binding protein 7, so a link potentially with TGF-beta, which we know is implicated in these diseases, for changes in spleen volume again. So again, suggesting there may be something perhaps mechanistically underlying this, but also predictive of response early on. So this is the conclusion from this presentation. Again, do look at it in full, but this is an exciting combination, along with a series of other exciting combinations of therapies that provide a novel aspect and novel slant on treatment, and more data with regard to efficacy as we presented at the ASH meeting. Thanks. I think it's quite difficult to know in terms of the many different agents that we look at for myelofibrosis, second line and perhaps even first line, certainly in North America with the approval of Indrebic, for example, which agents are going to end up being used where. For me, there are a number of very exciting combinations, and I particularly would highlight Navitoclax, but also the BET inhibitor, and I think as well other agents such as imetelstat. Lot of data at ASH, and I think a lot of them potentially are of interest. I hope that as we look at this kind of data with a full genomic profile and cytokine analysis, that we might be able to specifically target some of these agents to some patients. One particular thing, just keeping the focus on Navitoclax, is it does cause thrombocytopenia, so it's not going to be suitable for patients who have a platelet count less than 50, and probably not even for those with a platelet count of less than 100, and we may need to be looking at other therapies in that area. But nonetheless, I think it's very exciting.